We have used it for patients as low as 3.5 kilos and as big as 170 kilos.
Welcome to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We're excited to sit back down with Dr. Omar Alibrahim for part 2 of our discussion on negative pressure ventilation. Dr. Alibrahim is a professor of pediatrics at Duke University and pediatric intensivist at Duke Children's Hospital. Prior to moving to North Carolina, he served as the Pediatric Critical Care Division Chief and Fellowship Director at the University of Buffalo for more than 8 years, during which he worked with the pulmonology and respiratory therapy divisions to develop a strong negative pressure ventilation program.
Yes, we're excited to dive into part 2 of the nitty-gritty of negative pressure ventilation management. Starting off with a case, we're going to give you a 7-month-old girl. She's admitted with hypoxemic respiratory failure secondary to RSV bronchiolitis. Shortly after admission, she develops worsening respiratory distress despite adequate fever control, NP suction, and escalation of her high-flow nasal cannula support to 2 per kilo. A rapid response is called, and she is transferred to the PICU for negative pressure ventilation. So if I'm your PICU resident and you're telling me sort of what to order and where we start, we've talked about the physiologic rationale, but what modes exist for the cuirass? Where are we? What am I ordering so that they can put it into the machine?
Excellent. So this is a typical patient that we see in the PICU, and this is a typical patient that we normally would use non-invasive respiratory support, either positive pressure or negative pressure, and we choose to use negative pressure ventilation for this patient. So in terms of modes on the negative pressure ventilation device, there is 2 sets of mode. One set is the ventilation mode, and one set is the secretion clearance mode. So the ventilation mode has 4 types: continuous negative pressure mode, which is a CNIP mode, control mode, the respiratory synchronized, and the respiratory triggered. The respiratory synchronized and respiratory triggered, we did not really use as much, and we kind of speak about their pitfalls. Mm-hmm. So I think most of the things that I'm going to talk about is about CNIP mode and the control mode for 2 reasons, because those are the first 2 modes that were FDA approved when we used it. And those are the 2 modes that we became very, very comfortable and competent in using them. So back to our patient, the 7-month-old girl who came in with acute respiratory failure secondary to bronchiolitis, who is failing high-flow nasal cannula. So the decision is made to use negative pressure ventilation for this patient. So the first thing would be to do proper fitting of the cuirass, to use basically what size of the cuirass we're going to use. The shell or the cuirass comes in different sizes, from 0 as the smallest, and there's 11 sizes between pediatric and adult. So we do proper fitting and sizing, and as I mentioned, the cuirass has to fit between the suprasternal notch to the mid-abdomen around the umbilicus, mid-exterior lines on the sides. Once we do the appropriate fitting, then the respiratory therapist will put the protective foam around it just to help with the seal and minimize any pressure injuries to the chest wall. We have to make sure the patient has a cotton gown, and that will protect from pressure injuries, but most importantly, protect from hypothermia as well. Usually we move the EKG leads to the back, so nursing will do that before we implement. So once we made the decision, we made the appropriate fitting, we moved the EKG leads, we put the appropriate gown, then we applied the chest cuirass to the patient. There's a Velcro at the front, so basically similar to the BiPAP mask. You just apply this Velcro and adjust it just to make sure that's appropriately fit. It's not too tight as well. And sometimes if it's kind of loosely fit, there's some leak, we might put a little bit of towel underneath just to make sure the seal is appropriate. In terms of orders, almost always we start with the CNIP mode. And the CNIP mode is kind of akin to CPAP mode and positive pressure ventilation world. Usually the minimum pressure that you use through the CNIP mode is -8 centimeters of water. And the more negative the number, the more support the patient is on. Typically for these patients, we start with the pressures of -14 to -18. That's been our protocol when we evolved, I would say, from the initiation phase, and that we kind of settled what the patient would need. So let's say, for example, this patient, I would probably use -16, let's say, centimeters of water, and I would probably watch for 10 minutes. If I feel the patient is still struggling, I would make some adjustments by 2. And most of the patient, they will settle between -16 to -18, most of everybody. Of course, for a 6-7-month-old who would be agitated just because they didn't sleep, they're infants, you might need a little bit of sedation. Typically, we would use dexmedetomidine at initiation, You might use just one dose at initiation, and you might use an infusion if necessary. And I think later on we found that we have overused the continuous infusion, and most of these patients with the CNIP mode, they will need only at initiation. And actually, I have used it on myself as well to see it really is very comfortable. So you should not need a lot, but of course, some patients need some sedation during the course. So I will tell the resident, basically, we're going to use CNIP mode. Let's start at minus 16 centimeters of water. We'll keep the high flow nasal cannula on, mainly as a mode of oxygen delivery, just because there is no interface of the device with nose and mouth. So there will be a separate source of oxygen delivery. Most of the time, these patients would come as an escalation from high flow nasal cannula. So usually we'll keep them in the 2 per kilo of flow, and we'll keep them at FiO2 that will keep their SATs 92 to 97%. And again, we'll make some adjustment the first 15 minutes, and then we'll wait, and usually we'll make our assessments every 4 hours for these patients.
Oh, nice. I have a question.
Yeah.
If you've got the shell on top of the gown on the anterior chest, are your markers of workup breathing really just like respiratory rate and then how the nose and neck is looking?
Yeah, I mean, the shell is transparent, so you can see their...
Like sort of the movement?
The worker breathing, and if there are like retractions and tachypnea. And you can also, the back is exposed as well. So you can listen to the back, and you can see their tugging at the suprasternal notch and the supraclavicular area as well. So you'll be able to see the patient worker breathing and monitor that and listen to the patient while the shell is on them.
Oh, yeah.
So as someone who doesn't have as much experience with this, it seems that the fit in the seal is so important. And then the first step, kind of analogous to starting CPAP, is using this CNAP or continuous negative extrathoracic pressure mode, starting around negative 14, titrating to minus 16 or minus 18. Say you have this patient who's still working to breathe at minus 18. What would be your next step?
So the next step would be first to make sure agitation is not part of it. And also, to be mindful that agitation could be a sign of impending respiratory failure. So we don't want to mask this by providing sedation. So we already made that assessment that, no, this patient is agitated because they have a device on their chest and they're hungry and they haven't been sleeping well. And there's no signs of impending respiratory failure. So just kind of to put this on the side and as a reminder, I think, for all of us all the time. And usually if the sedation is not an issue, I would increase the support, usually by increments of 2. So from minus 18 to minus 20, watch for a few minutes, then minus 20 to minus 22. Usually you can go up to minus 30 to use for CNIP mode as more support. Typically when we reach minus 24, 25, that's when we escalate to the next phase, which is usually the control mode. In theory, I think respiratory synchronized would be the next step. But again, we had a couple of experiences with respiratory synchronized. I'll talk about kind of the pitfalls of it. But usually, typically, we escalate to control mode. The control mode is akin to BiPAP, the most closer in terms of analogy. And in control mode, we determine inspiratory pressure, we determine expiratory pressure, we determine a mandatory rate, and usually IE ratio 1:1. The inspiratory pressure is the main driver, like in the high-frequency oscillator, the mean airway pressure is the main setting that you set. In control mode, the main setting that you set on the vent is the inspiratory pressure. And usually if we have somebody on CNIP mode of minus 24, I would have probably their inspiratory pressure on the control mode to be around minus 24, 26. And their expiratory pressure usually is a positive number. And there is a 3:1 ratio between the inspiratory pressure and expiratory pressure. So if I decide to have an inspiratory pressure of minus 24, I would have my expiratory pressure to be plus 8. And the reason behind this was kind of recommendation of the company, but basically to create the maximum excursion of the chest and the driving pressure, if you will, to create the biggest startup volume. The respiratory rate on the vent will be determined by the patient rate plus 2. And let's say if the patient is breathing like 40 or 50 times per minute, we'll determine the rate on the control mode to be at 42 or 52 per minute. If the patient respiratory rate above 60, we usually cap it at 60. So it's very dramatic when you see the patient is a control mode. And I have used it on myself. It's not that intuitive, so you have to calm yourself into it. So it's very common that patients who are placed on a control mode, they will need sedation. It is extremely worrisome if they're not needing sedation. That's, in my mind, an indication to intubate because they're probably very altered and it could be hypercapnic, and that's why they're not requiring much sedation.
Oh, yeah. It's like art sticking them. They need to react to that.
Exactly,
yeah. So this is kind of the only time in the PICU I'm setting a respiratory rate of like 52 to match my patient exactly, right? That's pretty unique.
It's very dramatic, yeah.
But they do sync with it once they're calm, usually?
So that's an interesting point. They cannot synchronize with the vent, but they can breathe in between the breaths, if that makes sense. So if you set a patient respiratory, they say at 42, and they want to breathe at 60, they can do their additional 18 breath, if you will, but the ventilator would not provide them the synchronization that they need to, like compared to SIV, for example. Like there's a pressure support, there's like fine-tuned settings you do to provide that proper synchrony with the vent. In the control mode, they cannot really synchronize with the vent, but they can breathe in between these mandatory breaths.
So you're shooting to sort of make it so that they don't breathe too many times in between the mandatory breaths, but it's like mandatory. But
yeah, I mean, they will end up breathing with the vent ultimately, but I think I just try to be specific about the terminology, like the synchronization or breathing with the vent. They can breathe with the vent, but they cannot synchronize with the vent.
Got it.
If you know what I mean.
Because the vent isn't synchronizing with them.
Yes, yeah.
Nice.
A couple interesting points here I want to get more thoughts on. It seems really interesting to have active exhalation, like a positive pressure pushing air out the chest. And I imagine if there's like air trapping, that might be particularly helpful. Another observation is 1-to-1 inspiratory to expiratory ratio. That's very different than patients with positive pressure ventilation. Will you tell us more about why we would choose a ratio like that and what advantages that might offer some of our patients?
So that's kind of the default setting. And I think the advantage is not to use our typical 1-to-2, 1-to-3 ratio, because the main helpful part of control mode, if you will, is the inspiratory pressure. So you try for them to spend a reasonable time in the inspiratory pressure and not more time on the expiratory phase. And actually, if your patient is struggling, you can change that IU ratio to 2-to-1 or 3-to-1 to get them to spend more time during inspiration than expiration. Obviously, I mean, the patient has significant air trapping like an asthmatic. I don't think I would entertain using control mode. We have used CNIP mode for asthmatics and probably a dozen patients, and it worked really well. But I don't think I would advocate to use control mode for asthmatics, for example. I mean, we think of broncholytic like air trapping, but I think the air trapping related to UCAS, it's a very different, they don't have reactive airway component. And I think I'm very opinionated about the use of albuterol in broncholytic patients. I don't think we should use it ever in these patients. But that's also probably a different talk for a different occasion. But again, I think in these patients, I mean, they mainly have parenchymal disease and they have a bronchial disease. And to support their parenchymal component, they need more inspiratory support, more recruitment, more alveolar recruitment, and that will provide them the ultimate outcome of improving their worker breathing and their lung pathology, just to get them over that hump, basically, once their disease process is improving. It seems like I kind of triggered some internal discussions about albuterol.
It's amazing. Yeah,
a little comment here.
It's going to be another episode in the future.
Yes.
Oh yeah, we'd love to be part of it.
Yeah. So we've talked about how these patients, they can't sync with the control mode, obviously, because the ventilator is not detecting their breaths. It seems logical the next step would be to utilize a mode that can be synced with these patients. And you mentioned the respiratory synchronized mode and the respiratory triggered mode. Maybe start with defining what these things are and what advantages, but also what disadvantages they might have.
Yeah, I mean, the respiratory synchronized mode has been sold to kind of completely synchronize with the patient on breath, so the patient can determine their IE ratio. And basically, like the vent will detect the patient worker breathing and will be able to synchronize with it, basically from its name. The challenge with that is the sensitivity is challenging because it can be, the trigger could be coming from the QRS itself or coming from the airway, which is kind of a small sensor that you put through next to the nose or the mouth. The one that through the QRS, it tends to pick mainly kind of vigorous big breaths, and the one that's in the airway tend to pick more kind of shallow, small breaths. But the problem, if you use it through the QRS for like a baby and the baby is breathing okay, but because the sensitivity trigger in the QRS form is not as sensitive, it might think the patient is not taking breaths at all. It will fire back to the backup mode, which is usually control mode. And the opposite can happen if you have patient on the airway trigger, which usually picks very sensitive. So the patient could be apneic, But because it's very sensitive trigger, it could detect the patient is not apneic, the patient's still breathing, and try to synchronize with the patient, while the patient is apneic and needs to be like on a backup mode right away. So the pitfalls of these makes it kind of less favorable. So I've used it probably a handful of times. And I think because we were so good in using it in CNIP mode and the control mode, and that was approved 2-3 years after the initial approval. So we were already 2-3 years into our journey with negative pressure ventilation, when we were so comfortable with the first two modes. That became less popular, I think, in our unit, and we tend not to use it. And the respiratory trigger, kind of a similar concept as well. The only difference that the IE ratio is more determined. But I know colleagues who have used it, they have even more problems with the respiratory triggered. So that became out of favor, at least in our unit, which we are, at least in my previous institution, the most users in an inpatient ICU environment of negative pressure ventilation. And again, because we were just so good and so comfortable with the other two, that kind of became out of favor. And to my knowledge, and I recently saw the company of a conference in Europe like a year or two ago, that I think they're still working on that kind of trigger piece, and hopefully they will have a better solution for it. Because to me, the appropriate escalation should be CNIP mode, respiratory synchronized control mode. It should not be from CNIP mode to control mode. And that's also important in the weaning part of it, which I'm more than happy to talk about it as well. It should be like control, synchronized, and then CNIP mode.
Oh, yeah.
Yeah, out of curiosity, it seems that synchronizing with the patient is the major pitfall here that we're having the biggest issue with. And analogous to NAVA, with the risk of having undue complexity, do you feel like an esophageal probe might be one way to achieve this?
I don't see any reason not to do that. And I think they're trying to keep everything kind of non-invasive. So outside the body, maybe that's the trigger. But I'm more than happy to introduce this idea to their engineering team.
I mean, and you don't have conflicts of it, right? But also, Zach, this is the detection of respiratory effort in really small patients. That's like the PICU problem, right? Upstairs, I have probably 4 infants with flow sensors on full ventilators that are supposed to be able to detect a flow change and aren't doing a good job. So I understand that in regular BiPAP, it's hard to get it to sync well. And in negative pressure ventilation, it's like the same.
Oh. Yeah, and I think, to be honest with you, looking back at the syncing, I think once we find the patient, when we go to control mode, again, they cannot really synchronize with the vent, but they can breathe with the vent. If you use this control mode later on, most of these patients, the synchronizing is not really the problem. Their biggest problem when they get intubated, the secretion clearance, because these patients, the broncholytic secretion clearance is a big part of it. And we found actually many patients when we intubate, their compliance actually was not that horrible, but they have tons of secretions that without having an ET tube, it was not possible to get the secretions out. So it was very enlightening to me that at least I didn't feel like we could provide a more ventilated support, what they needed, like more aggressive, probably pulmonary toilet and secretion clearance more than anything else. But anyway, just to kind of add to that discussion.
Oh, yeah. Before we get into the weaning mode, you mentioned that you'll do the 2 per kilo of high flow for the FiO2. Maybe you'll get a patient up to minus 26/8 or something, and a rate up to 60. Do you have max support in mind? Do you have something to say, okay, this is as much as we'll do for this broncholytic, and then we kind of need to intubate them?
Yeah. No, I think, there's probably 2 points to this answer. One of them is the setting. One of them is what you monitor. So in terms of the setting, I think if somebody is transitioned to control mode, and I would say they are on 28/9 or 30/9, that's the most I would push from a setting point of view. So I think we can put this to the side now. But I think more important is how to monitor these patients and when to make the decisions to intubate. And I think this is always a very difficult question to answer on the clinical setting at the bedside. And I think reflecting on the BiPAP or positive pressure non-invasive respiratory support, thankfully in the most recent PALIC recommendation, section 7 for the non-invasive, they made it very clear that if you don't have any improvement within 6 hours or worsening, then you intubate. And that will be based on the FiO2 requirements, which is consistently has been proven to be a good metric. And that I think Robbie Kamani's studies from the Party Network in 2019 kind of showed that very, very clearly. And also, I think their worker breathing as an indication of their PCLE risk and their trajectory. Those are the 3 things I would use, like if I have somebody on BiPAP, like how much FiO2 they required, their worker breathing, and what's their trajectory. And that will determine my decision to intubate within that 6-hour period. Interesting, in our study, actually, the one we did on negative pressure ventilation, 2017, if you had the chance to look at the study, there were two groups of patients, responders and non-responders. And the non-responders actually failed at an average of 6.9 hours. So in my mind, with having this as the only probably best evidence, which is in a way matched, I think, what we know about other forms of non-invasive respiratory support, I use the same approach. So if I have somebody on negative pressure ventilation, I would look at their FiO2 requirements, because if I'm not able to wean their FiO2 below 60% and they're not achieving their SATs 92 to 97, if their worker breathing is not improving within this 6-hour mark, which is also mimicking other form of non-invasive respiratory support, and I know their trajectory is not going to be showing improvement in the next 12 to 24 hours, this will be my reason to intubate. So I have somebody, on minus 20 of CNIP and they're still going south. I don't think I would fuss around a lot with a non-invasive ventilation. I would consider intubation early on. So I think the settings are important. I mean, similar to the way you think about BiPAP. If you have somebody on 22/10, you might not push them to 28/10 or 12, right, before you intubate. And I would look at the FiO2 requirements, worker breathing, trajectory. So I would use the same principle supported by the best evidence that we have so far.
Oh, nice.
So you have this patient, you're on a control mode, you're on relatively negative, maybe like a -4, like -24 and +8. But you just get this sense, you get this gestalt that this patient's trajectory is worsening. Mm-hmm. You're worried about them needing to be intubated. What does optimizing a patient for intubation look like when you're in negative pressure ventilation? Is it purely just using high flow nasal cannula? But do you put on a BiPAP interface? And then do you just keep the negative pressure ventilation going during the rapid sequence intubation?
Yeah, great question. So I think in terms of optimization, I would use the same strategy that I would use for any other patient. The most important thing just to have them as stable for the intubation as possible. I always use rapid sequence intubation for these patients with apneic oxygenation. Usually we'll do this through the high flow nasal cannula. So if they have high flow nasal cannula, depends on their age, we'll put it at 5, 10, or 15 liters per minute. I have not kept the QRAS for rapid sequence intubation. That being said, actually, I had a talk for the fellows a month ago about negative pressure ventilation, and one of the fellows asked this question. And I said, actually, it's not a bad idea just to keep them on like a CNIP during that, because it provides extra recruitment and can be an additional layer of benefit to minimize their hypoxia. But I haven't done it, but it seems like it's very logical to do it. And it will not be in the way of intubating these patients. But I think my strategy would be to, like similar to any other patient with acute respiratory failure, I don't think I would use BiPAP. I would just use high flow nasal cannula for apneic oxygenation. I will do rapid sequence intubation with whatever combo medication that the unit is comfortable with.
Oh, yeah. I could see it. I could see having a bit of a mental block for having a patient's chest completely covered in something plastic while you're intubating them, right? It just feels, yeah. Yeah,
and I think that the trick would be to make sure, especially if the team is not used to that, I mean, just to make sure, like, once you intubate the patient, somebody has to take that off, like, right away.
Yeah.
So I think to have that mindset, or not to have one person dedicated to this, would make me think probably it's not a good idea to try on this patient, like, as long as everybody's not comfortable with it. Yeah.
So in your patients who are responders, how do you determine when it's time to wean, and then how fast do you kind of step it down?
All right, perfect. So let's say we have this 7-month-old broncholytic on high flow nasal cannula. We put on CNIP of -24, and she's doing well, right? So we do the assessment, as I mentioned, every 4 hours. And the goal of that assessment is two things. First, to assess the skin integrity, where the pressure points are, but also to assess the respiratory support. So we usually put the vent on a standby and take the shell out, look at the skin areas, especially on the sides, and listen to the lungs and look at the respiratory effort and the saturation. And usually that will be done by the provider, the bedside nurse, and the respiratory therapist as well. Once we feel the skin is appropriate, then we can put the shell back. And based on the assessment, either using any respiratory score that your department or division is going by, or the clinical assessment at the bedside, if you feel the patient is improving, then you decide to wean. Usually after the first 2 assessments, which is 8 hours after implementation, we start coming down on the high flow. So if the patient is 2 per kilo, you come down to 1.5, you come down to 1 per kilo. And then anything below 1 per kilo, you can just transition to regular cannula, basically just to provide an oxygen supplementation. After that 8-hour mark of assessment, then the following assessment, if the patient is improving, then you start coming down on negative pressure. So if the patient is on CNIP, -24, you come down to -22. and you make that assessment every 4 hours. In the very beginning, we used to get down to -10, -8 before they take the shield off completely. But I think when we became more comfortable, we have taken patient off when they're like -14, and we just take it off and put them on just a little bit of oxygen and see what they do. If they're not doing well, you can put them back. But we became, I would say, more courageous, I think, with its use, because it's very easy to put in, very simple to take off compared to BiPAP and CPAP. That's a bit different when the patient is on control mode. Let's say, for example, this patient was on control mode of -24 over +8 with a rate of 60. And this patient started doing well. There's two ways of weaning on the control mode. One way is to keep them in the control mode and wean the inspiratory pressure by 2 while keeping 3-to-1 ratio and maintaining the respiratory rate and adjust it on the patient rate +2. So let's say if the patient is doing well, you can come down to -22 over 7 and then come down to -20 over 7 and then -18 over +6 and so on and so forth. When you come down to +12 over 4, then the next will be to take the patient off. If the patient is doing really well, another way to wean is if the patient is control mode of -24 over 8, you can just transition to CNIP of -24 and then start weaning as on the CNIP weaning protocol, which is by 2 every time. So to recap, the first 8 hours after initiation, you come down on the high flow the patient is already on. And after the 8-hour mark of assessment, then every 4 hours, you come down by -2 if you're in CNIP. If you're in control, you can come down on the negative inspiratory pressure by 2 and keep the 3-to-1 ratio, or you can transition directly to CNIP with the same inspiratory pressure and just come down by 2 every time you do the assessment.
I'm curious to know why you prioritize weaning high-flow nasal cannula. And I say that because a lot of kids get high-flow nasal cannula, and gosh, it seems like complications of therapy is very, very low.
You could set them to the floor.
Tell me more about that.
Yeah, this is a great question. And I think we made the decision to do that because when you have somebody on 2 per kilo of high-flow nasal cannula, and we put the negative pressure ventilation on -24 of CNIP, and that's really what made the difference. It seems the extra support that they're getting from the high flow is just an extra support that they don't really need. And that's what really made the difference. And kids, can be very agitated. If you try like a very high flow of high-flow nasal cannula, it's very annoying. So in a way, part of it to minimize a support that they don't need and to minimize a source of agitation also that might contribute to their agitation during that time. So that was really the rationale behind it. We did not do a study to support that, but it seems like it's the logical thing to do. Again, being mindful that negative pressure ventilation what really made the significant impact in terms of respiratory support, not really the high-flow nasal cannula at that point of view.
Oh, nice. And as you walk your way through this weaning algorithm, at what point do you let them eat?
So one of the advantages actually of negative pressure ventilation that their mouth and face is free, so they can eat. And the only usually barrier of them not eating is the respiratory distress. So anybody with respiratory distress, regardless what their support, if they're tachypnic, an infant, you cannot really let them eat because the risk of aspiration is very high. So typically what we end up using kind of our protocol for any form of non-invasive respiratory support. If they're not improving or they're not able to be liberated from that and they're still in distress within 48 hours, we place an ND tube and feed them through it. If patient is on negative pressure ventilation and they're doing well and they just need to be on and they're not in distress, they can eat by mouth, regardless what kind of support they're on. So we have a few older asthmatic patients who are on CNIP of -14 or 12 and they still need it for like the next, the rest of the shift and they want to eat, we can allow them to have some clears. And patients who use it at home, they can use their therapies on it while they're still eating. So at home, from home perspective, there is no limitation. So the setting is not really a barrier. Most of the time, it's just the respiratory status. But at that time, our protocol, the protocol that we're going to adopt here, if they're still requiring negative pressure ventilation after 48 hours, that's a time to place a tube and to enterally feed them. Otherwise, if they're doing okay, they can eat by mouth.
Oh, excellent. Well, Dr. Alibrahim, we are so grateful that you took the time to join us today and really walk us through all these granular details of the program. Is there anything you'd like to discuss or recommend that our listeners read about before we wrap up?
I think, negative pressure ventilation is an old, new technology. The way I would look at it is another tool, as I mentioned, in the arsenal of tools that we have to support our patients. It really has minimal harm and potential benefits. It makes a lot of physiological sense. So I would encourage people to think about it more and more and consider using it more and more in our patient population with acute and chronic respiratory failure, and not to be hung up on the fact that we don't have the best evidence to support it, which I kind of completely see that point of view, but we don't have good evidence for many of the things that we do in the PICU, as long as we know what we're talking about. So I think it's a great tool to have. We have used it for patients as low as 3.5 kilos and as big as 170 kilos.
Wow.
So you can use it for a wide range of patients. And there's, I think, the benefit of the secretion clearance mode, which I know we didn't have the chance to talk about it in details, but it really provides that benefit of vibration and cough assist. So it's basically a chest PT and a cough assist device in one. You can adjust the modes and the ability, and you can use it for patients who are intubated, patient with a tracheostomy, and not necessarily on negative pressure ventilation modality. So you can use it very separately, just for secretion clearance. And patients have been very tolerant to it, and you can adjust the settings and the timing. So it can be very beneficial to these patients. So there's a lot of uses to it. And I would encourage critical care providers to read the review paper that we had in the respiratory care recently. It has very detailed overview of that treatment, and hopefully we'll collaborate in multi-center study to look at this. And my hope in the future, I think in an ideal world, to have a database to allow us to collect as more data as possible and to study some of these physiological parameters we talked about, what tidal volume we create, what negative pressure we create in the chest. And hopefully this information will allow us to design some useful clinical trials that we can use to guide our therapy in the future.
Well, thank you so much for your work in this area, for being a leader in the field, and thank you for sharing this information with our listeners. We're so excited.
Thank you both so much for having me on the podcast. And again, congratulations for all the great work that you do. And hopefully that will continue to be the case for many years to come.
Oh, thank you. And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers. And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.
So the cure that with a foam thing on their chest, much easier than having like a big mask shoved in their face. And I have noticed that with a lot of my patients over the years, with my own son as well, when he had that experience, unfortunately, but he did well.